pretty big topic I'm talking about here. I'm talking about frailty and physical function evaluation in kidney transplantation. For those of you who don't know me, I'm one of the transplant nephrologists over at UW Montlake. And I have no disclosures or no financial or commercial interest to disclose today. Some objectives for my talk today. Firstly, I want to just go over some definitions. I want to try to define frailty and physical function as well as physical performance. I also like to discuss why frailty and physical function and performance assessment are important in kidney transplantation. I'd like to discuss some of the most commonly used tools for assessments. There are a lot out there, both used in transplant programs as well as in the literature. And so I'll try to go over a few of them just to familiarize our audience. And finally, I want to discuss what tools we currently utilize here at University of Washington. So first off, let's start with what is frailty? And I think when you pose it like that, at least to me, I think it's not necessarily a very easy concept to describe in words. I think, however, if I were to show, I think the vast majority of you guys, this picture of this patient here and ask you, would you say this patient is frail or not frail? I would surmise that most of you would argue, yes, that appears to be quite a frail patient there. How about this picture here? I think similarly, I think it's one of those things where you kind of know it when you see it. Again, out of these patients here, out of these pictures here, which one do you think shows a frail patient, which, on the other hand, are not frail patients? And I'm not able to see the chat. I should have pulled the chat up there, but just for the purpose of time, I'll kind of move more swift. But the answer is actually all of these patients would be considered frail, and we'll talk about some definitions here as to why that is. So frailty. So there are various definitions to define frailty, but I think one of the most commonly ones that I encounter is frailty is an aging-related pathobiological process that's characterized by a loss of physiological reserve, as well as increased vulnerability to stressors. It was originally described in the elderly population as an adverse consequence of biological aging. It's an independent domain of risk that overlaps with, but is also distinct from comorbidity and disability in themselves. And I think it's important to note the use of biological age here. Biological age differs from chronological age. And I think this highlights the fact that, it's not just older patients who can be frail, but younger patients may also be characterized as frail. There are limited compensatory mechanisms in frail patients that lead to functional impairment and adverse health outcomes. This may include reduced mobility, falls, hospitalizations, institutionalization, as well as increased mortality or death. So I show this figure here because I think it demonstrates sort of the cascade of functional decline in patients, starting, from independence or being quite robust, all the way through to becoming frail or even disabled. And this is taking into account in the absence of any intervention such as physical therapy or rehabilitation. I think it's often difficult to recover from health stressors like infections, for example, take heart attacks or heart failure exacerbations, falls, fractures, or even, large surgeries in frail patients. How about frailty and kidney disease? Well, studies would show that, there's a prevalence as high as 8 to 16% of frailty in our CKD population. And then I think when you look at the dialysis patients, this rises to as much as 14 to 82%. And it's a quite wide range there, but this depends on the specific population you're talking about, as well as what assessment tool that you're using. And there are a number of assessment tools out there. More than 50% of patients over the age of 65 who are on dialysis are considered frail. And then just important to point out that a significant proportion of these patients are younger or, less than the age of 40. So just keeping in mind that although frailty is very much associated with advanced age, age is not the only factor that contributes to it. All right, so what about physical function and physical performance? Well, so physical function refers to a person's ability to perform actual physical tasks. And I think this can be both self-reported or can be measured. when we're talking about physical performance definitions, though, this is, although very similar to the definition of physical function, it denotes actual observed measurement of physical tasks instead of a self-reported metric. And then I think, again, going back to the point I made earlier, the conceptual framework of frailty is often quite difficult to measure and quantify. And, even still, there's little consensus regarding what specific elements should be included in the operational definitions of frailty. Thus, we frequently utilize surrogate measures to assess frailty. Surrogate measures including things such as one's functional capacity, measures of their physical function and performance, as I mentioned, and which is why I bring up physical function and performance here. It's often utilized to sort of characterize patients who are frail. So I want to bring your attention to this graphic. This is some USRDS data that was published in 2018. Looking at this figure here, this is looking at just males, but similar trends also apply to females. And I want to really just focus your attention on the transplant population versus dialysis. And as you can clearly see, patients who are on dialysis compared to those who receive a transplant have much lower life expectancy. And this is across a wide range of ages from age 20 to age 64 in this graphic. And so I think the important message from this is that transplant is certainly life-giving. I will acknowledge that, of course, I think there's likely some selection bias involved, as we might expect those who remain on dialysis. There may be some rationale behind this. They may be those who are sicker, and those who are selected for transplant, maybe those who, maybe have less comorbidity burden, maybe are a little bit less frail as well. But I don't know that this fully accounts for the difference in life expectancy that we see between those who stay on dialysis versus those who receive a kidney transplant. And we certainly know that remaining on dialysis is not the healthier option relative to those who receive a transplant, if it can be safely done in those patients. I also want to bring up this concept of a no benefit phenotype. Excuse me. I think this includes patients who oftentimes are identified as being the greatest risk for premature death while being on dialysis. They are also perceived to have some of the greatest urgency to need transplantation. And if they are subsequently listed, are oftentimes offered more marginal or what we consider high KDPI kidneys. And I think it's important to also remember that quality of life is an important factor that we must take into account as well. And marginal or more frail patients may not experience some of the same gains as other patients who are undergoing transplantation. Quality of life is affected by age, comorbidities, whether or not their transplant works after undergoing kidney transplantation, complications that they may encounter after transplantation, duration of hospitalization, and even medication side effects. And so, overarching point is that marginal candidates or our more frail patients appear to be at increased risk for complications after transplant, which can oftentimes negate any of the potential survival or quality of life benefits that we hope to gain from receiving a kidney transplant. All right, so moving along into the realm of transplantation. So in transplantation, increased frailty portends worse outcomes in both kidney transplant as well as all solid organ transplantation. This includes increased risk of delayed graft function, post-transplant delirium. They may have longer hospital stays, more frequent or early readmissions, more frequent requirement for immunosuppression, dose reduction and adjustment. And we also see an increased incidence of risk-adjusted all-cause graft loss and mortality. And this is even after taking into account some of the more traditional confounders that we see in this patient population. I show this figure here. I think this just highlights some of the numerous health stressors that are involved in that patients with kidney disease and also patients undergoing kidney transplant may experience. And so these are things like polypharmacy, just the major stressors that are involved in undergoing a big surgery like kidney transplant. Um, uh, Obviously, we know dialysis puts many strains on patients' health and quality of life. The immunosuppression required to successfully undergo kidney transplant is also a burden on our patients, and all of these things can contribute to development and worsening of frailty. All right, so continuing along. So I think it's important to recognize that frailty assessment currently is not part of standard practice in transplant recipient evaluation, and it's unclear how best to approach this based on our current guidelines. What I will say is the KDIGO Clinical Practice Guidelines on Evaluation and Management of Candidates for Kidney Transplant from 2020. It advises that we not exclude patients from kidney transplant just from age alone, but consider the context of comorbidities, including frailty, to assess suitability for kidney transplantation. And that's helpful, but I think at the same time, it's a general guideline. It doesn't offer, I think, detailed ways for us to go about it, and certainly doesn't offer any standard of practice for all transplant programs to abide by. Under the surgical issues section, it suggests that candidates be evaluated for frailty at the time of evaluation and while on the wait list to inform their post-transplant risk and enable strategies to further optimize them for undergoing kidney transplant. And I just highlight here the exact text of the guideline. And I think since frailty is an important risk factor for adverse outcomes in kidney transplant recipients, it certainly makes sense to evaluate potential kidney transplant candidates for frailty. Assessing these patients, of course, it's important to assess these patients, but not necessarily, and it's certainly not the goal of us here at University of Washington or any transplant program to introduce barriers to transplant, but instead to identify those patients who may benefit from more optimization strategies for transplant, such as things like even preoperative rehabilitation, or you may hear the term prehabilitation. I think assessing frailty using objective measures can certainly help inject greater objectivity into our evaluation process and also offer more transparency in the process. I think when we're talking to our patients and counseling our patients on whether or not transplantation may be best for them, I think it also helps guide some of these more difficult conversations in patients who, as I mentioned earlier, may be considered more marginal or maybe too frail to undergo kidney transplant. And I think it's also important to recognize that, and this is something that we previously did at University of Washington and many transplant programs still use to some degree, is the eyeball test. And I think it's important to realize that, the eyeball test is not very scientific, and it's certainly subject to provider and even transplant program biases that I think results in unequal opportunity for transplantation in our patients. And so, I think this guideline stresses the importance of some type of frailty evaluation in our patients. But how do we go about that, and what tools are available in our toolkit? All right. So, I want to try to take this time to go over some of the more commonly used frailty metrics in transplant. And so I think first I'll talk about the Fried frailty phenotype. And the Fried frailty phenotype, or FFP, is considered to be the most well-validated measure to quantify frailty. And this was developed in 2001 by Dr. Linda Fried and colleagues at Johns Hopkins University. It consists of 5 components that are both self-reported as well as measured. And essentially 1 point is given for the presence of each of those components for a total score of 5. And these components include unintentional 10-pound weight loss. And this is considered in the last year. Physical activity level, assessed by a standardized questionnaire. Degree of exhaustion. Gait speed, which is measured in terms of a 15-foot timed walk. And also hand grip strength, which is typically measured with the use of a hand dynamometer. And then, sorry, I'm freezing here. So again, one of the first metrics of frailty, and it was in this initial paper that Dr. Linda Fried and colleagues tried to define what frailty actually is. In Dr. Fried's original work, she showed that a score of 3 or more was used to define frailty and predicted things such as incident falls, worsening mobility, decreased ability to perform ADLs, increased disability, increased hospitalization, and even death in elderly population over a 3-year follow-up. Though testing seems relatively straightforward and it's not overly time-consuming, some of the major limitations with the original Fried frailty phenotype is that there is a need for specialized equipment, such as I mentioned the hand dynamometer used to assess hand grip strength, as well as a bit limited in patients who don't quite have the ability to ambulate well. So, since that original work, there's been development of what's called the modified Fried criteria. And in this case, we substitute a questionnaire. And I'll talk about this questionnaire here in a second, but a subjective questionnaire that, takes over the need for more specialized equipment and more specialized assessment that I think limits us in our day-to-day clinics and certainly in the transplant evaluation clinics. So that questionnaire is known as I'm sorry, my PowerPoint keeps freezing. That questionnaire is known as the short form 36 physical function questionnaire. And what this is it's a 10-item questionnaire, which is a subset of the medical outcome study short form 36-item questionnaire. And this self-reported tool includes questions regarding the ability to perform physical tasks, such as, for example, ability to walk multiple blocks. And it uses 3 different responses of not limited, being limited a little, or limited a lot. And these responses are scored on a scale from 0, 5, or 10, with a score of 10 being not limited to all the way to 0 when they are limited a lot. Scores for each question are subsequently aggregated to give a total score from 0 to 100, with the higher scores denoting better self-reported physical function or physical performance. This has demonstrated a robust association with both pre and post transplant outcomes. And I think it's important to note that since 2008, the Centers for Medicare and Medicaid Services have mandated that dialysis units collect this questionnaire as part of their I mentioned the 36-item kidney disease quality of life survey. And so some of this data is readily available if we want to utilize it. It's an instrument that was developed and validated back in 1994, and it combines generic health-related quality of life instruments, supplemented with some kidney disease-specific questions related to the effect and burden of kidney disease. It's been validated in patients on dialysis, not just in the United States, but in multiple countries. And of course, lower scores are strongly associated with higher risk of hospitalization, as well as increased risk of mortality. This is just an example of that 10-question component of the SF-36 that I mentioned earlier. And so just an example of some of the things I mentioned included like ability to walk several blocks, ability to lift or carry groceries, ability to climb several flights of stairs, ability to even bathe or dress yourself. As I mentioned, scored on that same scale, limited a lot, not limited at all, or limited just a little bit. All right, I'm going to try to briefly move through just a few other examples of frailty metrics in the literature, and they're used at some transplant programs. So another one is known as the Frailty Index, also called the Rockwood Deficits Index. And this frailty index conceptualizes frailty as an accumulation of deficits and considers between 30 and 70 different deficits assessed by both clinical signs and symptoms, some laboratory testing, presence of comorbidities, functional impairments, and disabilities. And a score is given by the ratio of the number of deficits present to the total number of items assessed, with the higher ratio indicating more pronounced frailty. And so I think it's important to know that, the Frailty Index, it does cover a wide range of deficits and generally provides a more quantitative measure of frailty. as well as its degree of severity compared to some of the other more commonly used metrics. It may lend itself to more effective longitudinal tracking of results over time, particularly as a tool for evaluating response to treatments or therapies. But I think there is a major limitation using the frailty index, and that is the fact that it's quite time consuming in its nature due to the wealth of deficits that it covers, thus really hindering its application and routine assessment. And I think it will be very difficult for many transplant programs, us included, to utilize in our day-to-day evaluation of our pre-transplant patients. And it's an example of the wealth of deficits and wealth of things that this metric covers. All right, another commonly used metric is known as the Short Physical Performance Battery, or SPPB. And what this is, it's an objective physical assessment tool of lower extremity function. It's originally developed in community-dwelling elderly adults, reflects physiologic reserve, and has been commonly used to assess frailty in various populations, including candidates for kidney transplantation. And this consists of 3 assessment components. One is standing balance, the other is walking speed, and another is repeated chair stands, also known as sit-to-stands. Each of these are scored from 0 to 4, and then some provide a total composite score of 0 to 12, with higher score representing better physical performance and thus less frailty. I think this kind of describes in more detail how this is performed, and I think for the purpose of time, I'll try to move through it quickly. But for balance, participants must stand and maintain their feet in various progressively more difficult positions, including side-by-side, semi, and full tandem for 10 seconds in each position. For walking speed, one measures the time it takes for a participant to walk just an 8-foot course at whatever pace is comfortable for them. And then for the chair stands or sit-to-stand aspect, participants must fold their arms across their chests and repeatedly rise from a chair as quickly as possible. And the time it takes to complete 5 repetitions is measured. And in some settings, you may also assess the number of sit-to-stand reps that are performed in a 30-second or even a 1-minute time frame. And I think it's important to the aspect of crossing their arms across their chest is to prevent utilization of their upper arms and upper arm strength, because really it's more focused on, as I mentioned earlier, assessing lower extremity strength, and also has a balance component to it as well. So, those are some of the, oh, sorry, I should mention that the SPPB has demonstrated strong associations with both pre and post kidney transplant mortality as well. It is limited by inability. There is some limitation by inability to perform in patients who have particularly lower extremity amputations or major impairments in their ability to ambulate. So what about here at University of Washington? What did we use? Well, something I purposely left off, and it actually is a very common frailty and physical performance assessment tool utilized both in solid organ transplant as well as well known in the rehabilitation literature is something that's known as the 6-minute walk test. And 6-minute walk test is an assessment of physical function, and it takes into account cardiorespiratory fitness, endurance, also takes into account strength and balance. And what we essentially do is we have patients walk along a set course, typically about 30 meters. And we essentially measure how far they're able to walk in 6 minutes. And this can be done at whatever pace is comfortable for the patients. They do have the opportunity to stop if they need to, pause. And as I mentioned, we allow them to walk at whatever pace is comfortable. It's also important to note that they can use any assistive devices that they would typically use to walk up to ambulate, with the exception of course, if they are wheelchair bound, that would disqualify them from participating in the 6-minute walk test. And so I think at least at University of Washington, we apply this to all patients who present for transplant who are over the age of 65. We perform this in them routinely, and also utilize it in other patients who might have other concerning findings that come up in terms of their evaluation that may, give us a sense that they may be more frail or have poorer physical performance. And we can have this performed even after their initial evaluation in the clinic. I think it's important to note that there are some strengths of the 6-minute walk test, so that one, it's quite well validated, as I mentioned earlier, in the physical rehab and even prehabilitation settings. I think the other very nice thing about it is that it doesn't require very specialized equipment other than just having a space to walk appropriately. And, it does require additional staff, though. And, I think we have been fortunate here at University of Washington is that it's also utilized by our colleagues in pulmonary medicine and lung transplant. And the respiratory therapists that are in the clinic, we oftentimes share the clinic with our pulmonary colleagues, and they have been well trained in this. And, when we were bringing this on at University of Washington, I must credit our own Dr. Yuharn Ng, who unfortunately is not here with us today, but I must credit her for playing a huge role in implementing this here at University of Washington. And I think it was able to be implemented more seamlessly because of the fact that, some of our colleagues over in pulmonary medicine were already utilizing this tool for their own evaluation. However, and this is quite new news for us here. Unfortunately, as of the new year, Medicare changed the eligible billing codes for reimbursement of 6-minute walk tests, such that now only pulmonary-related disorders are eligible for reimbursement for performing 6-minute walk tests in our patients. And so thus, we are currently, as of the last couple of weeks, been unable to perform this in our patients who do not present with pulmonary disorders at the time of transplant evaluation. And so we are currently looking at ways or other tools that we can utilize to assess assess frailty in our kidney transplant candidates. Another thing that we also perform in our patients is a frailty assessment questionnaire. And this is actually quite similar to the Freed frailty phenotype questionnaire. We perform this in patients over the age of 65. And as I mentioned, it's an adaptation from the Freed frailty phenotype, but again, avoids the need for specialized equipment, such as in physical assessment tools, such as the grip strength assessment using the hand dynamometer or a measure of gait speed. This is something that, we can perform even over the phone. It doesn't have to be performed directly in the clinic by patients, because essentially it's just a questionnaire. And what we're looking at, we still are assessing for unintended weight loss. So we asked in the last year, have you lost more than 10 pounds? And getting a score of 1 if this is yes. In the past, and then the other two parts of that are assessing exhaustion and physical activity. For the exhaustion component, we asked in the past week, do you feel that everything you do requires an effort, or do you feel that you just have trouble getting up and going? And it just requires an answer of yes to either of those two questions to get a score of 1. And then lastly, assessing physical activity. We asked, do you have difficulty walking more than 100 meters or 300 feet? Do you have difficulty climbing 1 flight of stairs? And again, if the answer is yes to either of those two components, that would also get a score of 1. And then we consider a score greater than or equal to 2, indicating self-reported frailty in these patients. And so again, I think, we may very well need to fall back more on our questionnaire as opposed to our measured metric of the 6-minute walk test in the clinic, just because of the limitations of Medicare currently. And I don't know that it's going to be a quick fix, but we are certainly looking at other options right now to assess frailty in our kidney transplant candidates. And so lastly, sorry to, you may have to break out your reading glasses for this, but this is just a table that kind of summarizes some of those major common frailty and physical function assessment tools that I mentioned earlier, and some of the strengths and limitations of them. And I guess we're running out of time here. And so, but I'm coming to a close now. These are some of my references, and thank you as we finish here just a little bit over time, and open for any questions or comments anyone may have.
Thank you, Daniel. Thanks for a nuanced discussion of complex issue. Questions for Daniel? Well, I'll just take the opportunity to ask that. I have a bunch of questions, but in particular, I appreciate that you talked about the importance of standardization, both in the measurement, but also in the way that that information's used, whether that be for selection or this prehab that you talked about. How do you how have you at university used information from 6 Minute Walk? How does the group discuss that and apply it to patients?
Yeah, absolutely. Good question. So, we certainly consider it in terms of the overall picture of patients. It is certainly a factor we consider in terms of one, whether or not to list these patients for transplant or to defer them, or not typically to deny them just in the sense of the metrics that they perform on the 6 Minute Walk test. But if we identify patients who are maybe perform not quite as well on the 6 Minute Walk test, we reach out to their referring nephrologist and suggest, opportunity to enroll in physical therapy. And I think because this metric is well recognized in the physical therapy and physical rehabilitation field, we try to provide goals. Our typical kind of cutoff is usually about 900 feet or 300 meters. And that comes from some of the literature actually dating back to heart transplant and heart failure in the heart failure sphere, denoting that those who perform less than 900 feet or 300 meters typically are considered more frail and have been associated with poor outcomes, both in heart failure in general and also in heart transplant. This has kind of been extrapolated to other fields such as kidney transplant as well. I think, and in an ideal world, and this is the term of prehabilitation has been utilized in the literature more frequently now. I think a goal would be to have even at each institution some standardized rehabilitation approach or prehabilitation approach that we can refer our patients over to even our rehabilitation staff at our institution to try to get stronger and identify particularly exercises that may be more relevant for our kidney transplant patients.
Thank you. Iris, did you have a quick question before we close?
Yeah, I don't know how quick, but I guess a question and a comment. I guess the question is, partly for the, dialysis providers in this, I guess, in this talk. So my question is, frailty, of course, CKD, ESRD, it's an obvious frailty. From the transplant end, of course, part of our assessment for frailty is risk stratification, mainly. And what Daniel was mentioning, of course, once we identify those patients, we try to reach out to a general nephrologist to hopefully intervene and modify, that frailty trajectory. And also, when we evaluate them, it's also a snapshot where they are. It's different in terms of when they just start in dialysis. They're just, getting used to the dialysis compared to maybe 3 months or 6 months down the line. So my question is for the folks who provide, dialysis care, is there, some form of frailty assessment and also intervention, in the maybe dialysis centers, knowing that, it's sort of difficult. They're, for those on hemodialysis 3 times a week, they feel wiped out. When will you squeeze in the rehab? So I guess my question is, has, the dialysis providers, has this been sort of looked at and sort of intervened on, regardless of, sort of transplantation candidacy? I guess I'm just posing that question so that, we can help each other move along the patients.
Yeah, excellent question, Iris. And I'll mention one thing, and I was talking to one of our colleagues down at UCSD actually in California, and I was discussing the topic of frailty and particularly as it applied to kidney transplant candidates, and he mentioned that because of experience that he's also had with referring his patients over to transplant evaluation, and just as you mentioned, the difficulty of even finding ways to do exercise outside of the time constraints of being on dialysis 3 or 4 times a week. And he's introduced, I think many of you have probably seen these mini cycle machines that he's placed at the feet of dialysis machines, and just allow patients to even utilize that while they're in their dialysis centers, to just offer some form of exercise and strengthening that can be done in the time that they're at dialysis. So I think, that's just one example that comes to mind, and certainly would like to hear what others may have experienced.
another big topic, I think, worthy of another grand rounds. I think there's a lot of work on this physical activity and exercise, and where that can be integrated for patients receiving dialysis and otherwise. Clearly very important pre-transplant as well.